Welcome our guest speaker. Welcome my professors. My presentation title today, Decision Making in Massive Rotator Cuff Tear. Massive tear, rupture of at least 2 cuff tendons. Factors to be considered in decision making: tear size, etiology, patient's age, patient's demands. Management options. Non-operative treatment. Older patient with low demands, few symptoms, diffuse or unfit for surgery. Non-operative approaches include activity modification, local steroid injections, physiotherapy. Physiotherapy aims to relieve stiffness, improve strength of muscles, scapular stabilization, coordination of muscle co-contraction, improvement of proprioception, deltoid rehabilitation. Arthroscopic rotator cuff repair. Various studies have shown better clinical outcome with repair of massive tear compared with non-operative or other surgical approaches. Various methods to help complete repair: margin convergence, single and double internal slides, bicep tendon augmentation, patch graft, combined with additional procedures such as sub-acromial decompression, acromioplasty, biceps tenotomy or tenodesis if required. Sub-acromial decompression. Repair of massive tear may be impossible due to tendon retraction, muscle atrophy, and fatty degeneration. In 1992, Bochart described 3 kinematic patterns with massive tears. One of them, the stable fulcrum type. Tear of the superior cuff with intact anterior and posterior cuff provide a suspension bridge for coupled deltoid and cuff action. With this biomechanical model, older individuals may be adequately treated with debridement and decompression without repair. In 1995, Rocod performed subacromial decompression with acromioplasty in 53 shoulders with irreparable rotator cuff tear, showed significant improvement in pain, function, and range of motion at average follow-up of around 6 years. Gartzman reported improvement in shoulder function in 78 and 79 100% of patients treated with open debridement and decompression for irreparable cuff. However, he also reported them to inferior to rotator cuff repair. The ideal patient for achieving improvement with subacromial decompression: patients with intact anterior and posterior cuff, which provide a stabilizing effect on the humeral head and permits the deltoid muscle to provide abduction force to the shoulder joint, the stable fulcrum model. Long head of biceps tenotomy. In massive cuff tears, long head of biceps is very often the reason for pain because it's entrapped between the superior migrated head and acromial. Poilot, in a retrospective study of 68 patients with irreparable tear treated with biceps tenotomy or tenodesis, 7,800% patients were satisfied with the results. Improved postoperative shoulder motion due to alleviation of pain, no major role in improving joint mechanics. Disadvantages of tenotomy: loss of biceps strength, bob-eye deformity, superior migration of the head. Suprascapular nerve release. Controversial. Kostor showed reversal of suprascapular neuropathy after massive repair. Mellon found similar results with postoperative EMG studies. Lafosse found no difference between cuff repair plus suprascapular nerve release and cuff repair alone. Subacromial spacer. Sinkovic introduced a novel technique by implanting a biodegradable spacer into the subacromial space, reduces the subacromial friction during shoulder movement. After 3 years follow-up, a sustained benefit, especially in pain reduction. Constant score improved from 33.4 to 65.4 points. Partial repair. Bochart, in his historical paper in 1991, proposed that the rotator cuff can be functional if the anterior and the posterior forces are balanced and coupled with the deltoid function. Massive rotator cuff tear can be managed with creation of this force. This can be achieved by partial repair of the massive cuff tear. This is opening a new horizon in the management of massive irreparable rotator cuff tear. Bochart showed satisfactory result with open partial repair at follow-up of around 21 months The mean active elevation is improved 90.8 degree. Dural D, in a retrospective study of 24 partial open rotator cuff repair, showed a 90 to 100% patient satisfaction. Borsellini treated 67 patients by arthroscopic partial cuff repair. There was a significant improvement in the mean constant score at the 3 years follow-up. However, partial repair has no role in cases where the subscapularis or infraspinatus tears are irreparable or the deltoid function is impaired. Batch grafts. Primary repair of massive retracted tear may be impossible without creating excessive tension on the sutures. Therefore, autograft or synthetic graft material has been developed. Mora, although the torn cuff is non-functional, a synthetic graft provided a mean for redirecting force transmission to the glenohumeral joint. The batch graft may also act as a subacromial spacer. Odonert implanted transoceanic fixated patch combined with subacromial decompression in 41 patients with massive rotator cuff tear. Improvement in constant score mainly on the pain from 25.7 to 72.1 after the mean follow-up of 43 months. Superior capsular reconstruction, recently developed by Japanese surgeon Mihata in 2012. Early clinical result of superior capsular reconstruction gave excellent pain relief, increase in shoulder function and range and strength, even in young patients. Biomechanical contribution of superior capsular reconstruction. Ishihara found that the superior capsule played an important role in passive stability of the glenohumeral joint. In massive cuff tear, the superior capsule is completely torn, results in the superior migration of the humeral head. Reconstruct the superior capsule is a reasonable procedure to restore the superior stability. Indication of superior capsular reconstruction: age, relatively young age, involve the tendon, supraspinatus and or infraspinatus, subscapularis tendon intact or repairable, muscle atrophy, severe atrophy, fatty infiltration, Goutelier type 3 or 4, cuff tear arthropathy, grade 1 or 2. Tendon transfers. Chronic tear may lead to tendon retraction and the cuff may become irreparable. Tendon transfer has long been used in shoulder palsy, most of the time in obstetric brachial plexus palsy. The idea came to use similar procedure in massive reparable rotator cuff tear. Posterior-superior tears. The Tesmas dorsi tendon transfer has been advocated to cure posterior-superior tear or to restore external rotation. In a systemic review, this procedure improved active mobility, function, and pain, and they found 35-degree gain in active forward elevation, 10 degrees in active external rotation. The strength and abduction was improved from 1.9 to 3.2 kilogram. Anterosuperior tears. Pectoralis major tendon transfer aim to restoring internal rotation and to contain the humeral head. Al-Hassan reviewed 30 patients with pectoralis major tendon transfer. Pain score improved from 7.9 to 4.2. Constant score improved at 57 months of follow-up from 28.7 to 52.3. Tendon transfers should be reserved for young patients with no glenohumeral arthritis, no pseudoparalytic shoulder, with an intact deltoid. The procedure mostly improves mobility and elevation in external or internal rotation, provide pain relief, but rarely result in improvement of strength. Reverse shoulder arthroplasty, restoring deltoid tension and creating a fulcrum sufficient for shoulder anterior elevation. A functional deltoid muscle is mandatory. Despite good short-term results, some studies found high rate of complication and limited implant life expectancy. Reverse shoulder arthroplasty should be reserved for all patients with painful, massive, irreparable cuff tear arthropathy, despite conservative treatment. Now the time comes to put these options in algorithm. We divide the patient of massive rotator cuff tear in two main categories: traumatic and chronic. Traumatic, the majority of traumatic are treated with arthroscopic repair. Some very few cases from the traumatic category are treated non-operative. This for elderly patient unfit for surgery or refuse surgery. and chronic with glenohumeral arthritis, a non-operative treatment at first. If failed, go for reverse shoulder arthroplasty plus or minus tendon transfer according to positive hornblower test. With no glenohumeral arthritis, we go for surgery if failed non-operative management. According to the acromial-humeral distance, if the acromial-humeral distance is more than 7 millimeters, we go for subacromial decompression, biceps tenotomy, plus rotator cuff repair. If the acromial-humeral distance less than 7 millimeters, go for subacromial decompression plus biceps tenotomy. If the acromial-humeral distance less than 4 millimeters, go for reverse shoulder arthroplasty plus or minus tendon transfer. Thank you.